So just to recap that, the number of participants, there was 68. In the treatment group, there was 35 with 74% being male, and the placebo was 33 with 79% being male. In this study, regarding the comorbidities, all patients had type 2 diabetes with a GFR over 30, meaning that they were categorized for CKD as stage 3A or 3B. They were given a dose of 360 micrograms daily for 4 weeks. The outcome was the dephosphorylated uncarboxylated MGP, as well as T50. This is propensity time, a biomarker of arterial wall calcification propensity. And then they took this a step further, and they had the blood specimens frozen, and 4 years after the trial completion, they had them analyzed for the T50. Results showed no difference in the baseline dephosphorylated uncarboxylated MGP in either group. The treatment group had a higher Aganston score, and what this is coronary artery calcification that is shown in CT imaging. There was no significant difference in T50 at the first follow-up and the second follow-up, and for the entire trial period, there was no correlation between T50 and imaging markers of arterial calcification at baseline, 6 months, and between 6 months and baseline. So overall, there was no benefits shown. The strengths include that there was comparable demographics, that it was adjusted for variables, that the intervention was well tolerated, and that diet was taken into considerations. Limitations include that it was one geographic region, and that there is a high number of dropouts that may have impacted the results. So the quality rating is positive. This is my visual abstract. I did it in a PIO format. And just to kind of recap for the population, age is 50-70 years, CKD stage 3 or greater. The 4 countries we've already reviewed. There was 1 pre-post intervention trial, and there was 3 randomized trials. For the intervention with oral vitamin K2, 1 study was 375 micrograms daily for 12 weeks versus the control. 1 was 360 micrograms daily for 4 weeks. All were given intervention. The 3rd study was 360 micrograms daily for 6 months versus placebo, and the 4th one was 400 micrograms daily for 12 months versus the placebo. Outcomes showed no significant difference in the pulse wave velocity between the groups, but there was a significant with p0.01 improvement noted in the diabetic patients. 1 study showed reduction in dephosphorylated uncarboxylated MGP in 88% of the patients, and 2 of the studies there was no significant differences. This is another slide with a lot of information, but it is important. So the conclusion and the evidence grade. The conclusion is that there's limited evidence of improvement in vascular calcification and stiffness for individuals aged 50 to 70 years with chronic kidney disease stage 3 or greater and treated with vitamin K2 at a dose of 350 to 450 micrograms per day for at least 30 days. There was potential benefit for slowing the progression of vascular stiffness, and there was potential benefit for patients with diabetes that have CKD, although we don't really understand the correlation. And overall, further research with alternative study design would be recommended. And according to the Academy's evidence analysis library, this was graded as 2 fair, using the following criteria: that this was a study of strong design for a PIO question, that there was inconsistency among the results, that there was some doubts about the adequacy of the sample size for type 1, type 2 error. There was some doubt about the statistical or clinical significance of the effect, and there was some minor doubts about the generalizability. Strengths and limitations of the systematic review. So the strengths include that these were well-designed studies. 3 were randomized controlled trials and 1 was an intervention trial. They were inexpensive. The intervention was inexpensive and well tolerated, and that the demographics and the organization of the study was similar in all 4. And the limitations, the first one I used with some hesitation. Obviously, each country, the study was limited in generalizability, but there's actually 4 countries, so I suppose you could argue that there's some generalizability because it's technically 4 different populations. And then there was no studies that measured the baseline physiologic vitamin K status. There was only 1 study that assessed the dietary intake, and that there was small sample sizes for 2 of the studies. The implications for nutrition research: there should be more research looking at higher doses and a longer time frame of supplementation with vitamin K2. They should include the biomarkers for physiologic vitamin K both before the intervention and after the intervention, and include vitamin K intake as part of the assessment. And then for clinical practice, this would be for a renal dietitian, to estimate the vitamin K status, assess the vitamin K intake at every assessment and follow-up, just as part of nutrition care for renal patients. And when there's a deficiency noted, to provide education about food sources and preparation. Also to use as a standard of care, the use of the vitamin K biomarkers during the nutrition assessments, and also for a standard of care to just consider standard or supplementation for everybody with vitamin K2 at a dose of 350 to 400 micrograms. And this would be possibly even more beneficial to the patients that have diabetes along with their CKD. These are my references. Thank you very much.